prognosis. In the first stage, inasmuch as the majority have no symptoms at all, and an indefinitely large proportion of others have only slight symptoms for many years, one may be optimistic about the prospects of the prostatic who is seen in the first stage of his disease. About 50% of prostatics have acute retention, and the great majority of these reach chronic complete retention within 5 or 6 years. On the other hand, I have followed one case 14 years from his single acute prostatic retention and seen no return of symptoms. A number of other cases I have followed more than 5 years. The younger the case, the slower the average progress of the disease. The prostatic who begins to have symptoms at or beyond the age of 70 usually reaches chronic complete retention within 2 years. In the second stage, when the patient is in chronic incomplete retention, his prognosis is gradual failure of the bladder and passage to chronic complete retention more or less rapidly according to his age, his infection, the shape of the prostatic obstruction, and the irritability of the prostatic urethra. In the third stage, when the patient has reached chronic complete retention, his expectation of life depends upon his treatment. The patient who refuses operation and neglects himself speedily comes to grief. The patient who takes care of himself may come to grief by unavoidable accident. But the passage of the catheter to empty a bladder in retention is not in itself necessarily fatal. Indeed, the patient who empties his bladder 3 or 4 times a day by means of the catheter is in no worse condition than the patient who empties his bladder the same number of times without a catheter, excepting only that the passage of the instrument is more or less irritating. I know a number of men who have employed a catheter with entire satisfaction for more than 10 years, and one of my patients died of renal insufficiency after more than 40 years of catheter life. Yet sooner or later, in spite of all our care, inflammatory or renal complications destroy the patient unless he submits to operation. Prognosis as regards infection. The prostatic who constantly passes the catheter is doomed to infection in spite of whatever precautions he may take. Aseptic rules of catheterism are solely for the purpose of making this infection as mild as possible. The infection always occurs within a month or two, usually within a week or two of the beginning of catheterism. We look for it and are happy to see it pass, since it establishes the patient in a condition which either is, or may usually be reduced to, a mild acid cystitis. The larger the prostate, the more likely is the infection to be difficult to control. Careful patients with paralyzed bladders and complete retention without enlargement of the prostate do much better as a rule than prostatics, for the prostate is a constant source of infection and trauma. Infection of the kidneys and ureters establishes itself at about the same time as infection of the bladder. It is quite as difficult to dislodge, but if the retention is well managed so that the kidneys do not suffer much back pressure, it is easy to control for a time at least. Prognosis as regards kidneys. Most prostatics who are not relieved of their retention by operation die by urinary septicemia with pyelonephritis. The issue may be rapid or slow. Watson collected 207 cases of prostatism treated by the catheter, with a little less than 8% mortality within a month. But the more usual danger from the kidneys is slow, insidious failure due to mild retention and mild infection.